So we reviewed the data on 75 AML patients, including 36 new patients and about 38 relapsed AML patients. And this was done in collaboration with the immunotherapy platform at MD Anderson. We looked at a number of immune checkpoints, including TIM3, LAG3, CTLA4, PD1, and others. And what we found were the PD1 was overexpressed in patients who had AML, both relapsed as well as newly diagnosed AML as compared to the healthy controls. And the overexpression was seen in all T cell subsets, including the CD8 T cells, CD4 effectors, and the CD4 regs. The other immune checkpoint that emerged to be of interest, which was a surprise to us, was OX40. And we saw that the OX40 levels also appeared to be higher, especially in the CD8 and the regs in the leukemia patients as compared to healthy controls. So these two seem to be the ones of interest to pursue in AML. Now we're doing a similar approach looking at the expression in MDS as well as in CLL. So there actually have been monotherapy trials of these agents in both AML and MDS. There was a trial that included a number of hematological malignancies, and that had 8 patients with AML who received single agent nivolumab. And there were actually one patient who had a stable disease that lasted for about 6 months, but no other responders. And these were heavily pretreated patients. We did also study in MDS, where we are looking at patients who have had azacitidine or decitabine and are failing, and they get single agent nivolumab or ipilimumab. What we have seen in that study, which will be presented as an oral presentation at ASH by Dr. Garcia-Monero, shows that with the Nivo in 15 patients, we actually saw no responses as single agent. With the IPI, however, we have seen responses with 3 out of 10 patients showing a response as a single agent. So there may be some single agent activity with IPI, is what we're thinking at this time. With the combination, however, we are seeing that the response rates are doubling as compared to what we would get with azacitidine alone. So when we do azacitidine and nivolumab, we're getting almost double the response rate. More importantly, the responses seem to be very durable, with patients who are achieving CR, CRI, pretty much maintaining them throughout, not losing it. So we think one of the reasons for this is because azacitidine actually manipulates the immune system, and this has been shown by studies both by solid tumor experts as well as by our group, where azacitidine increases the T cells in the bone marrow, increases antigen exposure, and also increases PD1 and CTLA4 expression on the surface of T cells in leukemia blasts. And that's why we think the combination is not giving us a 1+1 additive effect, but a synergism, where people who did not have expression of PD1 or T cells now start having it after the AZA, and we're able to then use that expression with the PD1 inhibitors. So in MDS, the study we're doing has multiple arms. 2 of these are for patients who have prior treated MDS with the hypomethylating agent. So these are usually high-risk patients. Once they fail hypomethylator, the median survival is usually somewhere between 6 months if they are high risk at the time of failure, or if they are low risk, it's about 14 months. And what we're doing is we're giving single agent nivolumab to these patients, and we treated 15 such post-HMA MDS patients with single agent nivolumab. We actually did not see a response, so out of 15, 0 responses. We're now doing the similar one with ipilimumab, where we've treated about 10 patients who have received azacitidine and progressed with MDS and have got IPI, and we've seen morphological remissions in 3 of them. And the other 2 arms of the study are for the frontline untreated MDS, so we're taking patients who are intermediate to or high risk MDS, and they're getting a combination of azacitidine with nivolumab. And in this one, in the first 12 patients we've treated, we've seen 9 patients with CR. So that's about 75% CR rate, which compares favorably to an expected CR rate of about 40 to 45% with azacitidine alone. And now that same study is opening for the IPI arm, so we will be enrolling patients with azacitidine and ipilimumab, and hopefully we'll have that data by mid next year. The one study that we have enrolled the most patients at this time is with azacitidine with nivolumab in patients with AML who have had prior therapies or relapsed AML. We have about 53 patients on this study. We'll be presenting this data tomorrow morning as an oral presentation. What we're seeing is the overall response rate is about 34-35%, which compares favorably to an expected overall response rate of about 17 to 18% with azacitidine alone. And again, more importantly, that is what is happening is that the people who are achieving a response are maintaining it for a long term. So usually we expect with azacitidine alone in salvage AML, the response duration would be anywhere between 3.5 to 5, 6 months. And we are now seeing a median response duration of about 9 months with patients also beyond 1 year in salvage AML maintaining response. So very similar to what has been seen in solid tumors, it seems that the overall response rate may be somewhere in the range of 25 to 30%, but those who do get a response have a durable benefit. And more importantly, we are doing a lot of T-cell immune analysis, including different T-cell subset changes in population as well as checkpoint expression. What we're seeing is those people who have a high T-cell infiltrate to begin with, either total CD3 or CD8 favorable infiltrate to begin with, are those who are responding. And as they respond, the total T-cell infiltrate in the bone marrow continues to go up, indicating that not only is there a durable clinical benefit in the ones who respond, but there's actually a favorable buildup of an immune profile. So which kind of explains why these patients may be having this durable benefit. So this is exciting for us, and we're going to build on this data further.